My name is Timothy Byars. I'm the President and Chief Education Officer at Radicle Health. And as always, I'm joined by our CEO, Eloise Theisen. These are part of our Radicle Community webinar series. And so the community is comprised of advocates and educators and healthcare professionals and cannabis stakeholders. And what we intend to do is provide support and information and resources to our members. So for information about how to join the Radicle community, just go to our website, radiclehealthcare.com, click the community link. When you sign up, you receive access to some of our newsletters that we have published in the past, and I promise we will publish another one at some point in the future. You get access to our full on-demand video library, which includes recordings of all of our webinars, as well as additional interviews and other media. You also get access to our private Facebook group. So it's free to sign up and it's free to be a member. It simply adds you to our email list. I do also want to remind everyone that we have an array of curriculum options at a range of price points for students and working professionals. So whether you are helping customers make good choices, or maybe you're treating patients, maybe you're advocating for social change, or maybe you're just using cannabis yourself, you need evidence-based factual information about cannabis. Radicle Health curriculum is up to date, it's comprehensive, and it's informed by both clinical experience and expertise and by instructional design expertise. So please reach out to us if you have any questions about the curriculum, or you can go to the website and click one of the many education links. So this presentation is for educational purposes only. The information here presented today is not intended to be a substitute for medical advice. The information is not meant to help in the diagnosis, prognosis, or treatment of any virus, disease, illness, or condition. If you are using medical cannabis, please work with an experienced and informed medical cannabis clinician. All right, so today, we're talking about THCV, which is a very curious molecule. So I'm going to spend the first 30 minutes or so talking about pharmacodynamics. And we're going to get a little bit into the weeds, so buckle in. That's going to be the first half of the webinar. And then Eloise is going to take over and she's going to discuss clinical indications and talk a little bit about some specific THCV products that are actually available in the online marketplace. So THCV, tetrahydrocannabivarin. It's a naturally occurring cannabinoid. It's a compound found in very low levels in cannabis plants, although modern breeding techniques have produced plants with increasing amounts of THCV by dry weight. THCV was discovered in 1970 by a man named Edward Gill. He was working with Roger Pertwee, who is an Englishman, pretty renowned in the cannabis space. And they detected the cannabinoid in a legal tincture of cannabis called cannabis BPC, which was actually available and legal in the UK in 1970. In 1971, a gentleman named Franz Merkus elucidated Gill's work and named the new cannabinoid delta-9 THCV. Now, more recently in popular media, cannabis chemovars with high levels of THCV are sometimes called diet weed. And the reason is because there are some studies that suggest that this cannabinoid can in fact suppress appetite. There was a small double-blind study that suggested that THCV might be used as an appetite suppressant and as a novel therapeutic to help treat obesity. Low levels of THCV in common chemovars might account for the results of two national surveys that illustrate how cannabis users tend to have lower prevalence of obesity than non-users. And there's a different study that suggested that cannabis use is associated with smaller waist circumferences and lower BMIs, body mass index, which is a measure of body fat based on height and weight. We'll discuss THCV in the medical literature a short while later in the presentation. So the molecular structure of THCV is pretty similar to THC. The only difference is that THCV has 2 fewer carbons in its carbon tail. And because of the difference, you will sometimes see THCV referred to as a propyl analog of THC, a propyl group contains only 3 carbons. So even though THCV varies from delta-9 THC only by the length of its carbon chain, it does possess a different pharmacological profile at most molecular targets. I do want to cover briefly the biosynthetic pathway of THCV. So just like any plant, cannabis plants extract CO2 out of the atmosphere, and they use that CO2 to form sugar. Then the plant uses those sugars, and through multiple enzymatic conversions, it eventually creates 2 compounds. One's called geranyl pyrophosphate, and the other one's called alivitolic acid. And when those 2 compounds react, and when they get catalyzed by a specific enzyme, they produce CBGA. However, when geranyl pyrophosphate combines with divarenolic acid, and it's catalyzed by an enzyme, the plant produces CBGVA. And these are really the 2 main branches of nearly all cannabinoids, so sort of the 2 grandparent branches. So THCV, of course, is formed via the divarenic acid path. And these cannabinoids that are derived from CBGVA are sometimes collectively known as the varins. So, we know that decarboxylation converts CBGVA into CBGV, and then various enzymes can convert CBGVA into varin cannabinoid acids like CBCVA, CBDVA, THCVA. And THCVA is the biological precursor to THCV. And when THCVA is decarboxylated with heat or UV light, that's how we create THCV. One interesting note about THCV is that it has a boiling point of about 428 degrees Fahrenheit, 220 degrees Celsius. This is slightly higher than the boiling point of THC, which has a vaporization point of about 314 degrees Fahrenheit. So if you have a product that contains both THCV and THC, and you're wanting to get the THCV is coming along for the ride as well. So THCV's pharmacodynamic activity is a little bit complicated. Beginning in the 1970s, some researchers thought that THCV was responsible for about 1/4 of the potency of THC. But more recent research suggests that THCV might not produce any psychoactivity on its own at all. Now, the differences between these results of the studies might be accounted for by differences in the studies' methodologies. So, for example, some studies might have used very low doses of THCV, and some studies use very high doses. When we're looking at cannabinoid pharmacodynamics, a good place to start is with the cannabinoid receptors. So currently, the research suggests that THCV might be both an agonist and a neutral antagonist at CB1 receptors, and it depends on the concentration. So at low concentrations, and we're talking about like 3 milligrams per kilogram of body weight or less, and this would be administered via IV. These were the studies that where they had these results. THCV is likely an antagonist at CB1. At high concentration, so anything above 10 milligrams per kilogram administered via IV, THCV might act as an agonist at CB1. And this is when it might produce some mild psychoactivity. All of this remains pretty speculative, however. And just to give you a sense of what 10 milligrams per kilogram of body weight means, I'm about 160 pounds. It's about 70 kilos. So 10 milligrams per kilogram would be about 700 milligrams of THCV. So probably not, something that we're going to see a whole lot in the marketplace. There has been some speculation that THCV might be metabolized into a compound that has some agonist efficacy at CB1. We know that delta-9 THC exhibits markedly less potency at CB1 than its 11-hydroxy metabolite. And given the structural similarities between THC and THCV, maybe THCV also undergoes some metabolism into some type of 11-hydroxy metabolite that's an agonist at CB1. The only data that we have on this is again coming from Pertwee and his team at University of Aberdeen. And they actually suggest that yes, there is an 11-hydroxy metabolite of THCV, but it behaves actually as an antagonist, a neutral antagonist at both CB1 and CB2. So probably not exhibiting any kind of indirect agonism through its metabolite. So recall that delta-9-THC has a 5-carbon side chain. THCV has a shorter side chain. It only contains 3 carbons, and the shorter side chain of THCV might suggest why THCV has lower binding affinity at CB1. Longer side chains increase cannabinoid receptor binding affinity. You get up to 7 or 8, and then you start to have diminishing returns after that. But we do know that the 7 carbon chains they have the highest binding affinity that we know about. We should also note that it's sometimes difficult to distinguish between neutral antagonists and inverse agonists. So an inverse agonist is kind of like an agonist, except it does the opposite of what an agonist does. Currently, the consensus is that THCV is a neutral antagonist at CB1. This means that it's binding at the main receptor, but it's not producing any results in the cell. It's just competitively binding there, and it's preventing other agonists from binding to those cell receptor types or sites. So determining whether an antagonist is really an inverse agonist requires a certain amount of ligand efficacy at the receptor. It requires a detectable degree of constitutive activity in the receptor system. So pretty much all G protein coupled receptors, even when you don't have a ligand that's binding to a main site, there's still some activity that's going on. And so, when you have an inverse agonist, it's going to stop that constitutive activity. So in order to measure it, the cell itself has to have some kind of measurable constitutive activity. Traditional receptor theory didn't even have, we didn't even know about inverse agonists in traditional receptor theory. This is somewhat of a recent discovery. There's a recent study that suggested that THCV doesn't inhibit or stimulate GTP gamma binding in animal models at low concentrations. And so it's considered a neutral CB1 receptor antagonist rather than an inverse agonist. So don't worry about what GTP gamma is. It's one of the G proteins that an inverse agonist would affect if it were an inverse agonist acting at a receptor. To further muddy the water, there's some additional evidence that supports the idea that THCV might also be an indirect agonist at CB1. So at higher doses, THCV seemed to potentiate the antinociceptive effects of THC, so it was helping with the pain relief. There is some speculation that THCV might be able to inhibit the uptake of both anandamide and 2-AG, our natural endocannabinoids. There's also some uncited internet speculation that perhaps THCV can inhibit the enzyme Pha. But I haven't actually found any evidence in the medical literature that supports that. And also we've seen, we've seen other molecules that inhibit rat Pha. So, molecules that exhibit efficacy at inhibiting Pha in rat models, but fail to have similar effects in humans. And CBD is actually one example of that. All right, so that's CB1. CB2 is a little bit more straightforward. So the data suggests that THCV is a partial agonist at CB2. And if the data is correct about THCV ligand binding types, THCV might be effective at treating things like inflammation and depression and eating disorders and other chronic diseases through CB2 activation. And it can do so without activating CB1 receptors and causing impairment. This is kind of the holy grail of the pharmaceutical industry and cannabinoid receptors. They want something that will activate CB2 receptors and get all of those potential therapeutic benefits, but not activate CB1 and get that terrifying euphoria that happens when you activate CB1. All right, so that's CB2. We're going to move on into a few other receptor types and explore how THCV might interact with them. And we're going to start with the serotonin receptors. So THCV is an agonist of the 5-HT1A receptor. And 5-HT1A is a subtype of 5-HT. And again, these are all serotonin family receptors. The 5-HT1 is probably the most common of all the 5-HT receptors. They're located in really high densities in the central nervous system. And when you activate these receptors, it can do things like decrease blood pressure, decrease heart rate, decrease body temperature. And 5-HT1A receptor agonists can do things like, relieve anxiety and depression and nausea and pain. And again, THCV is an agonist at these receptors, and so it can help potentiate all of these beneficial effects. They have been tested pretty rigorously, both in humans and in animal models. Mice that have been bred without 5-HT1A receptors demonstrated an increase in anxiety behaviors, and clinical studies suggest that patients with panic disorders tend to have impaired 5-HT1A receptor function. This receptor activation also, there's speculation that it also might improve symptoms related to schizophrenia and Parkinson's disease. So 5-HT1A receptor agonists like THCV have demonstrated efficacy for the treatment of things like anticipatory nausea. And there really is no current treatment for anticipatory nausea. It's a condition of physiological nausea and vomiting. It's believed to be a learned response to chemotherapy. It's a condition that seems to link psychological, neurological, physiological systems all together. And again, we think that THCV is an agonist at 5-HT1A, so it can activate these receptors and possibly introduce these positive therapeutic effects. Then we have the TRP receptors. So we're just going to talk about TRPV1 and TRPV2. But there is some research to suggest that THCV can stimulate and desensitize the TRPV receptor channels, V1 and V2. So TRPV1 receptors are expressed in sensory neurons. They're also expressed in the brain, but they mediate pain and temperature sensation. So this receptor is commonly referred to as the capsaicin receptor. This is the molecule in chilies that makes it taste spicy. And also these receptors help detect noxious stimuli. So TRPV1 receptors are activated by temperatures greater than 109 degrees Fahrenheit. They're activated by acidic conditions, by capsaicin, and they're also activated by allyl isothiocyanate, which is that really pungent compound that you find in wasabi and very hot mustards. And the activation of TRPV1 produces a painful and burning sensation normally. And so, you would expect that TRPV1 antagonists would help to mitigate pain, especially acute pain. They do, but they're less effective at treating chronic pain. So TRPV1 agonists seem more effective at managing chronic pain and they do that through prolonged exposure and receptor desensitization. So what happens is if you bombard these receptors with a bunch of agonists, eventually they just turn off. They downregulate, they go back into the cell, and they stop transmitting their particular signal. So that's been one effective way that agonists at these receptors can actually help with pain relief, especially with chronic pain relief. So THCV, but also other cannabinoids like CBD, CBN, CBG, CBGV, they're all TRPV1 agonists, and they can all desensitize this receptor. We should also note that the activation and desensitization of TRPV1 by cannabinoids has been associated with some anti-cancer effects as well. TRPV2. So these receptors are pretty similar to TRPV1. The activation and desensitization of TRPV2 can help mediate things like inflammation and chronic pain. And these receptors are actually potential targets in the treatment for things like cancer and inflammatory disease, and also cardiovascular disease. So TRPV2 activation might enhance the uptake and efficacy of chemotherapy, especially in triple-negative breast cancer patients. Triple-negative breast cancer, it's an aggressive disease. It has limited therapeutic options. Chemotherapy is the first line of treatment, but triple negative breast cancer is often resistant or unresponsive to chemotherapy. All non-acid cannabinoids, except for CDC and CBN, are potent agonists and can desensitize TRPV2. Again, there's research to suggest that these interactions might contribute to the analgesic, anti-inflammatory, and maybe even anti-cancer effects of cannabinoids, including Thcv. All right, we're going to get into the weeds now. We're going to talk about the Gpr receptors, and we're going to really talk about Gpr55. So Gpr55 is what's known as an orphan receptor, or it used to be an orphan receptor. So in biochemistry, orphan receptors refer to receptors for which no endogenous ligand has been identified. So in other words, researchers actually discover the receptor before they discover what molecule binds to the receptor. And we know if we find a receptor in the human body, there's some molecule that our body produces that will bind to it. We just don't, with orphan receptors, we haven't discovered it yet. And when we do discover those endogenous ligands, when we discover the receptors first before the ligands, they're typically named with this GPR prefix, and it stands for G protein receptor. And then it's followed by a number. And I think, and I can't confirm this, but I think that they're just numbered chronologically in the order that they're discovered. So in the G protein coupled receptor family, I think there are about 100 orphan receptors. And then when the endogenous ligand is discovered, the orphan receptors are considered adopted. So GPR55 is an adopted a receptor, and it's modulated by the endocannabinoid system. There's a second one also called GPR18. And some researchers are suggesting that these are actually novel cannabinoid receptors, but there's not consensus there just quite yet. So GPR55, they're located in the brain, they're in the gastrointestinal tract, they're in the pancreas, they're in the adipose tissue, which is our body fat. Researchers discovered an endogenous ligand that binds to GPR55. You can see the name here on the slide. If you want to try to pronounce that, have at it. I'm just going to call it LPI. GPR55 receptor activation has been associated with things like cancer cell proliferation and disease progression, inflammation, certain types of pain. So for example, when we breed mice without these receptors, without GPR55 receptors, they have lower levels of inflammation, inflammation-induced pain, lower levels of neuropathic pain after this really awful experiment that they do called nerve constriction. Just a quick sidebar here. I think this is interesting. I want to be clear that in most cases, when GPR55 receptors are activated, they produce adverse effects, right? They essentially the activation is associated with some type of disease progression. So it begs the question, why do we have these receptors in our bodies? Why do we have receptors so when they're activated, they're bad for us? From an evolutionary perspective, how does that serve us as a species? Why would natural selection, preserve these receptors and these traits over time? And one suggestion has to do with a concept called antagonistic pliotropy. So pliotropy is this idea that genes in our bodies cover multiple mechanisms, and antagonistic pliotropy is the idea that when they do this, they might facilitate reproduction in early life, but then they go on to cause problems later in life. So we all have to remember that there's a single item on natural selection's bucket list, and that's have babies. So evolution will gladly trade away your golden years for anything that helps you produce more in your younger years. So this might be one reason why things go haywire as we get older. It might be that because they served a purpose when we were in our childbearing years. All right, so back to GPR55. The study of GPR55, when you read the literature, it seems like the study of it is uniquely difficult. There's not a whole lot of unequivocal language in the medical literature about this receptor type. In fact, there's some research that suggests that a single ligand can bind to GPR55 in multiple manners. So for example, there's some data that suggests that Thcv can be a partial agonist. at GPR 55, and there's other data that suggests that THCV inhibits LPI. So again, that's the endogenous ligand that activates GPR 55, and this might help explain why THCV can potentiate the analgesic effects of THC. Remember, in previous studies, we found that that was kind of weird, right? It was actually potentiating the pain relieving effects of THC. Remember that CB1 receptor antagonists tested in clinical studies during when they were testing drug treatments for obesity-related disorders, demonstrated efficacy at reducing neuropathy in patients with type 2 diabetes. And this was an unexpected result, right? CB1 receptor agonists, things that activate CB1 receptors, they've been widely tested, and they demonstrate efficacy at treating neuropathy and neuropathic pain. So consequently, what these researchers suggested was that maybe there's a non-cannabinoid receptor target that was the mechanism that was responsible for this effect, that where THCV was inhibiting pain. And we just stated that GPR 55 knockout mice are less sensitive to the development of chronic pain. So maybe it's this negative allosteric modulation of LPI at GPR 55 that's responsible for the pain-reducing effects of CB1 antagonists. And again, we expect CB1 agonists, things that are activating the receptor, to provide pain relief. When you have an antagonist, you wouldn't expect it, but maybe it's through this other mechanism. It's through a mechanism outside of a cannabinoid receptor. So THCV, it's a CB1 antagonist and CB2 partial agonist. And again, there's data that suggests that THCV can significantly inhibit LPI-induced activation of GPR 55. And even though we don't know the precise role of GPR 55 in things like food intake and metabolism and pain relief, that hasn't been fully elucidated. THCV's putative ability to inhibit food intake and help with pain signaling, help reduce pain, that might be mediated, at least in part, by this negative allosteric modulation of GPR 55. All right, let's move to GABA receptors. A couple of different kinds of GABA receptors. We're only going to talk about one kind. They're GABA A receptors. These are the targets for multiple types of prescription drugs, things like barbiturates and benzodiazepines and anticonvulsants. GABA A receptors also mediate the effects of alcohol. Drugs that target GABA A are they're either agonists, they activate GABA, or they are positive allosteric modulators. They help facilitate the activation. So agonists and positive allosteric modulators increase the effects of GABA activation. They produce things that, they're anxiolytic, they're anticonvulsant, they're amnesic, sedative, hypnotic, euphoric, they have muscle relaxing effects. Generally in a healthy individual, these are things that we want to produce, right? We like GABA neuron activation generally. Antagonists and negative allosteric modulators produce the opposite effect, right? They're not really used in prescription medications. There is one called flumazanil. It's an example of a negative allosteric modulator at GABA A, but it's really only used to reverse an overdose of benzodiazepines. So it's kind of like naloxone with opioids, and it would sort of knock all of those little benzo compounds off the GABA receptors. Now, when you look at the medical literature, you'll see that cannabinoids are often referred to, especially the CB1 agonists, they're often referred to as inhibitory. And the reason is because they're mimicking the effects of inhibitory neurotransmitters, things like GABA and serotonin and dopamine. There are two broad categories of neurotransmitters. There are some that are inhibitory, and there are some that are excitatory. And when we're talking about those two types, really what that means is that the inhibitory ones, they tend to reduce action potential. So that a nerve isn't, the likelihood of a nerve firing is reduced if you have inhibitory neurotransmitters. And then we have excitatory neurotransmitters that would potentiate the action potential. And so the potential for that nerve to fire is increased with those excitatory neurotransmitters. We know that CB1 activation can have inhibitory effects, including effects that impact GABA release from GABAergic neurons, right? GABA neurons have CB1 receptors on them. And so if you have an agonist at CV1, it's possible that if they're binding to receptors, if they're binding to GABA receptors, they're gonna inhibit GABA release. So CB1 activation by CB1 agonists can reduce GABA signaling. And there's data that's suggests that THCV can block that CB1 mediated inhibition of GABA release from GABAergic neurons. And this might account for some of the anxiolytic and anticonvulsant activity attributed to THCV. All right, we are getting pretty close to moving to the therapeutic indication. So I just want to provide a little bit of background. In the 1990s, early 2000s, there were a lot of companies who were looking at CB1 inverse agonists and producing evidence that demonstrated the efficacy of CB1 inverse agonists for the treatment of things like metabolic syndrome, type 2 diabetes, dyslipidemia. And the evidence was convincing. In 1994, a company called Sanofi Pharmaceuticals, they developed a drug called rimonabant. This was the first commercially available CB1 receptor inverse agonist. Rimonabant produced effects at CB1 that are the opposite of those produced by CB1 agonists like THC, for example. So, THC increases appetite. Rimonabant did the opposite. It suppressed appetite. And in a randomized, double-blind, placebo-controlled trial, rimonabant produced a significant reduction in body weights of subjects. And the results were like between 5 and 15 pounds over a 2-year period. And this was relative to the placebo group who were, and the active group, they were taking about 20 milligrams of rimonabant daily. It was approved by the European Commission in 2006 for the treatment of obesity, and it became available for prescribed use in the UK. By 2008, it was available in 56 countries. Now, unfortunately, rimonabant also produced significant anxiety. It produced depression. It produced suicidality. Guess what? CB1 receptors do more than just control appetite. So in October of 2008, the European Commission determined that rimonabant's risks outweighed its benefits, and they withdrew the drug from the market in January of 2009. The withdrawal of rimonabant from the market led to a rapid abandonment of pharmaceutical research looking at the development of these CB1 inverse agonists, and there were a ton of them. And just a few. There was one called seronabant. This was discontinued. Taranabant. These guys were in phase 3 clinical trials, so they invested a ton of money already. They discontinued in 2009. Rozanabant discontinued in 2009. Otenabant, they suspended all research in 2009. Drinabant, they were in phase 2 clinical trials. They suspended research in 2009. And again, these were really effective at treating obesity and facilitating weight loss. And there were a lot of other CB1 inverse agonists that were being looked at. Last sidebar for my part of the presentation here. One of the abants seems to have survived. So in 2018, Drinabant was licensed by a company called Opiant Pharmaceuticals. And in a press release, they stated that they're intended to use it. They're going to develop a treatment of acute cannabinoid overdose. And they're going to use it as an injectable for administration in emergency room department settings. So when they have people who come in who have THC intoxication, this is especially important in kids because in kids it produces the opposite effects of what it produces in adults. It can have cardiorespiratory repressive effects. And so sometimes kids go into coma if they eat too much THC. They're going to inject it, and hopefully it will have, again, that sort of same effect as naloxone with opioids. All right, Eloise, you ready?
I am. I was, every time I hear, when we talk about the Abants, I think of those Muppets characters. They're like, do, 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 do. And then the guy comes in, he's like, ba-da-da-da. I got a little giggle out of that because there's a lot of Abants out there that we didn't know about. All right, thank you, Timothy. So we're going to talk a little bit more about metabolic syndrome, diabetes, the ECS, and obesity. And just a way to initiate the discussion of possible therapeutic indications of THCV, we'll recall that CB1 receptors can stimulate appetite. So when we block these receptors, especially with an inverse agonist, it can lead to a decreased appetite. Driven largely by the search for an effective treatment for metabolic syndrome and obesity, a lot of CB1 research has been focused on decreased consumption and satiety research, weight loss. Metabolic syndrome is the name given to a number of conditions that tend to occur concurrently and increase our risk of heart disease, stroke, type 2 diabetes. These conditions include high blood pressure, high blood sugar, obesity, especially body fat around the waist, and high cholesterol or high triglyceride levels. All right, next slide, please. So, yeah, that was right. Next slide. Okay. ECS and obesity. So overall, there's a rapidly growing understanding about how the endocannabinoid system affects body weight control. Current data suggests that modulation of our ECS can have significant implications for taste sensations, food-seeking motivations, feelings of satiety, managing metabolic imbalances or abnormalities, insulin resistance, ghrelin production, weight control, body mass index, there goes my brain trying to put two words together, body mass index, fasting glucose and lipids, gut microbes, which might influence our mood, and weight gain associated with increases in pro-inflammatory cytokines. So it's well established that the endocannabinoid system regulates appetite. THC, or rather the activation of CB1 receptors, is what stimulates our appetite. That's what's releasing that ghrelin production. Suppressing activation of CB1 should reduce appetite. A study in CB1 knockout mice suggested that these mice with inactivated CB1 receptors were resistant to obesity and had improved energy metabolism. Clinical trials with the Avant family of medications reinforced this hypothesis. And evidence that cannabis and cannabinoids impact weight loss also exists in human trials. Authors of a study published in the American Journal of Epidemiology, wow, today's not my day, used data from 2 large surveys of US adults aged 18 or older to estimate the prevalence of obesity as a function of cannabis use. These surveys were the National Epidemiologic Study on Alcohol and Related Conditions at the National Comorbidity Survey. The study suggested that on average, cannabis consumers who consume at least 3 times per week were less likely to be overweight than non-users. For example, the data from one survey found that cannabis consumers had about a 16.1% obesity rate compared to 22% in the non-cannabis consumers. In the second survey, the findings were 17.2% versus 25.3%. Also, these differences were not accounted for by tobacco smoking. We know tobacco smoking is correlated with lower obesity rates. Another study suggested that there's a significant association between cannabis use and smaller waist circumference. There are some cannabinoids that are neutral antagonists or negative allosteric modulators at CB1. So for example, THCV and CBD respectively. The results of these studies we've looked at suggest that cannabis consumers tend to be less obese. But are these cannabis consumers mostly acquiring and consuming chemovars high in CBD and THCV? Most likely not. There are pharmacodynamic nuances happening here that are far more complex than simply turning off CB1 receptors. Nevertheless, research suggests that THCV produces hypophagic effects in both fasted and non-fasted mice. And hypophagia is the suppression of caloric intake, usually resulting from a reduction in feeding behavior. And the existing research suggests that delta-9 THCV produces anti-obesity effects by increasing energy expenditure. So we're putting out more than by reducing food intake. In addition, delta-9 THCV seems to reduce the time that normal weighted mice spend close to a food hopper. Again, experiments specifically with THCV were initiated after somewhat conclusive evidence that CB1 receptor antagonists suppress feeding and reduce body weight in animals and humans. With diabetes, it is now a chronic health condition known to impair the mechanism the body uses to convert food into energy. And the CDC is estimating that about 500 million people are living with diabetes worldwide. The number is projected to increase by 25% in 2030 and 51% in 2045. And it's also estimated that approximately half of the people with diabetes don't even know they have it. Enzymes converting the food that we consume into glucose, which is then released into the bloodstream. And the word glucose is derived from a Greek word that translates as sweet. Glucose is a simple sugar. Our bodies convert glucose into energy. In fact, glucose is the primary source of energy for our cells. However, glucose cannot typically enter cells by itself. It requires help from a hormone. And when amounts of sugar get too high in the blood, it stimulates the pancreas to create and release that hormone, which we know is called insulin. And the insulin hormone attaches to insulin receptors on cells. The activation of insulin receptors opens a channel that enables the glucose to flow into the cell. This is especially important for all cells in muscle and fat tissue, as well as liver cells, where glucose is converted to glycogen and stored as a source of energy. If you have diabetes, your body does not make enough insulin, or the body can't efficiently use the insulin that you produce. This result is the same. Too much sugar remains in the blood. Too little sugar can be used by the cells to create the energy the body requires. And as we know, there are two types of diabetes. In type 1 diabetes, the pancreas doesn't make enough insulin. The lack of insulin results in fewer insulin receptors becoming activated and less glucose entering into the cell. In type 2 diabetes, the pancreas is producing enough insulin, but the insulin receptors have downregulated or desensitized. The cells have become insulin resistant. The pancreas compensates by releasing more insulin, which just ends up floating around the bloodstream and massively raises insulin blood levels. Both types produce two adverse effects. First, the cells don't receive enough glucose and cannot generate the energy required to function properly. Second, rising levels of sugar in the blood can cause damage in the body, and these effects can result in things like nerve damage, heart disease, vision loss, and kidney disease. And one of the tests that we use to check for diabetes is called a fasting insulin test. Fasting insulin is a measure of insulin levels in the blood after at least 8 hours of fasting. And low fasting insulin levels are associated with type 1 diabetes, but also with pancreatitis or other conditions associated with malfunctioning pancreas. High fasting insulin levels are associated with insulin resistance, type 2 diabetes, and obesity is also associated with some rare conditions with pregnancy and is indicative of the use of other prescription medications such as corticosteroids and even oral contraceptives. So when we look at cannabinoids and diabetes, we can look at a study in 2013, which included about 4,500 adult men and women from the National Health and Nutrition Examination Survey from 2005 to 2010. Of those 4,500, 579 reported current cannabis consumption and 1,975 reported past consumption. Current cannabis consumption was associated with 16% lower fasting insulin levels than that measured in the non-cannabis group. The researchers also reported significant associations between cannabis use and smaller waist circumferences. The study also suggested that cannabis users have lower insulin resistance. The lead researcher, Murray Middleman from Harvard Medical School, suggested that cannabinoids are interacting with insulin or with insulin receptors and helping to reduce resistance to the insulin, which helps cannabis users maintain a normal blood sugar level. The correlation between cannabis and lower body mass and lower insulin resistance suggests that cannabis users might be less inclined to develop diabetes. Again, high fasting insulin levels is a predictor of diabetes. In fact, a double-blind, placebo-controlled study suggested that patients with type 2 diabetes and dyslipidemia might be able to improve glycemic control with THCV. In this study, researchers demonstrated that THCV significantly decreased fasting plasma glucose in type 2 diabetic patients. They concluded that THCV might provide a template for the development of new therapeutic agents for glycemic control, especially for type 2 diabetics. These human trials support previous conclusions from studies in mice where researchers concluded that THCV is a potential treatment against obesity-associated glucose intolerance, with pharmacology different from that of CB1 inverse agonists. Dyslipidemia is characterized by abnormally high cholesterol or fats in the blood, which can increase risk of clogged arteries or arteriosclerosis, heart attacks, and stroke. This condition is associated with adults who are obese, who have unhealthy diets, and who do not exercise. In dyskinesia and Parkinson's symptoms, a study in mice suggested that THCV might delay the onset and decrease the intensity of dyskinesia, which is characterized by involuntary and erratic movements of the face, arms, and legs. Dyskinesia is an adverse side effect of some Parkinson's disease medications. Furthermore, a different study in rats suggested that the antioxidant properties and the ability to activate CB2 receptors but block CB1 receptors might help alleviate Parkinson's symptoms. For example, THCV might attenuate impaired motor responses and delay neurodegeneration in Parkinson's disease. And THC may inhibit many of the well-known effects of THC. Data from a clinical trial in 2016 suggested that THCV can inhibit these effects, but also suggested that THCV might potentiate some effects too. It feels like this molecule can't make up its mind sometimes. 10 male cannabis users, so very small study, were given either 10 milligrams of pure THCV orally or a placebo daily for 5 days, followed by 1 milligram of THCV intravenously, of THC, followed by 1 milligram of intravenous THC on the 5th day. THCV was well tolerated and subjectively indistinguishable from placebo. THCV improved delayed verbal recall and inhibited tachycardia, and 9 of the 10 participants reported THC under THCV condition was subjectively weaker or less intense. However, the THCV in combination with THC adversely impacted short-term memory, and THCV might be explored as an antidote to THC overconsumption. So recall that THCV is likely an agonist at the 5-HT1A receptors, and these receptors are located in high densities in the central nervous system. 5-HT1A receptor activation, remember, can decrease heart rate and help relieve anxiety and depression. And as mentioned earlier, mice bred without 5-HT1A receptors demonstrated an increase in anxiety behaviors, and clinical studies suggest that patients with panic disorders might have impaired 5-HT1A receptor function. The study completed in vivo supported this hypothesis that THCV can enhance 5-HT1A receptor activation, and these researchers also concluded that THCV might have therapeutic potential for mitigating adverse effects of schizophrenia. And during clinical trials of rimonabant, there were some compelling evidence that in addition to an anti-obesity potential, the drug also had significant anti-addiction efficacy against a broad range of addictive substances. Although intended to control overeating and obesity, rimonabant was soon recognized as able to prolong abstinence from smoking compared with placebo in phase 3 clinical trials. It was also effective at reducing self-administration of many other drugs of abuse. During the past 12 years, researchers have begun looking at other pharmacological solutions to substance use disorder. For example, researchers hypothesized that perhaps the side effects of rimonabant were related to its ability to penetrate the blood-brain barrier, and in part its effects on brain receptor interaction. So peripherally restricted CB1 receptor antagonists or inverse agonists were proposed for controlling binge eating, obesity, and metabolic diseases because these molecules cannot penetrate the blood-brain barrier. Some researchers suggested that the adverse effects of rimonabant were related to CB1 inverse agonism. Therefore, it was proposed that neutral antagonists at CB1, those without any inverse agonist tendencies, should retain the therapeutic anti-addictive effects without the unwanted side effects. Preclinical studies with new synthetic compounds have shown promising results. Other ligand binding types and mechanisms have been proposed as new approaches for substance use disorder as well, including negative allosteric modulators, Fa and MAGL inhibitors, fatty acid binding protein inhibitors, and non-impairing phytocannabinoids with CB2 binding profiles. For example, there's some evidence that CB2 activation in the brain impacts reward and addiction. Data suggests that brain CB2 receptors are important in many addiction-related behaviors, and CB2 receptor agonists might be used in the treatment of substance use disorders. Delta-9 THCV is, of course, a CB1 antagonist and a CB2 agonist. As mentioned earlier, current research suggests that THCV is not an inverse agonist. Furthermore, Delta-9 THCV can also act at the 5-HT1A receptor, can stimulate and desensitize human TRPV1 and TRPV2 channels, and can modulate GPR55 signaling, all of which suggests that THCV might reduce drug self-administration and relapse without significant adverse effects. And adverse effects of THCV. Pure plant-derived THCV did not elicit the types of adverse effects associated with rimonabant, psychiatric, and the anxiety-like reactions. It's important to note that the reasons for this difference are not fully understood. It has been suggested that THCV might competitively inhibit one of the signaling pathways of one or more endogenously produced endocannabinoids as an antagonist at the CB1 receptor activity. Perhaps the effects of THCV are predominantly mediated by interactions with non-cannabinoid receptor sites, such as the 5-HT1A, GPR55, or TRPV receptors. So a lot of the reason Tim and I wanted to present this webinar today is because we're starting to see THCV products hit the market. And while THCV does not occur in large amounts naturally in the plant, we are starting to see hemp varieties that are specifically being bred to have higher levels of THCV, and they are now hitting the market for consumer consumption. So this is a product that's actually come out of Colorado through Wana under their Optimals brand, which is currently being sold only in Colorado in dispensaries. And this came out of them doing a study, a nitro study, where they looked at using THCV. It was a double-blind, placebo-controlled study, excuse me, of about, was it 100 people, Tim? I think, was it like 99? And essentially for 90 days, they took 2 milligrams, either 1 milligram of THCV or 2 milligrams of THCV. And the participants did not know that they were taking something that could potentially help them lose weight. And on average, people lost about 10 to 11 pounds over those 90 days and did not change any of their dietary habits. They didn't increase their exercise or anything like that. So there was actually some pretty good promise that it was helping with weight loss without an increase in any other side effects or adverse effects. So Wana has partnered with the farmers to get some of this Nitro V THCV and use this product here. You'll see per piece that their dose is actually a lot less. They do 0.5 milligrams of THCV, 10 milligrams of CBD, and 0.1 milligrams of THC. But this product is nano enhanced, which is why their THCV dose is quite low. It's only been on the market for less than a month. And a lot of consumers are reporting an increase in focus and energy, some decrease in appetite. We haven't had it on the market long enough to really determine if there's been weight loss. And most people are taking 1 of the gummies a day, but some are taking 2. The study that was also done with the Nitro-V study demonstrated increase in sleep, decrease in pain, decrease in anxiety. There was a lot of positive results that came out of it. But what we're going to actually see on the market needs to still be determined. Next slide, please. Here's another product out on the market under the Rare Cannabinoid Company and Thcv. You can either get as a single extract, or you can get a CBD THCV combination. And you'll see here it's a little bit blurry, but the delta 8 THCV is about 18 milligrams per dropper full, or 1 milliliter, and it has no THC in it whatsoever, no delta 9, no delta 8 THC in it. So should be non-impairing. I have had some people who've taken this and said that it definitely helps with their focus and concentration and energy. So I think one of the areas we might start to see THCV used more for is possibly ADD, ADHD, brain fog, maybe chemotherapy brain, people who have Lyme's disease and don't have the ability to focus so well. So again, it's very new cannabinoid to the market, so it remains to be seen what the real world evidence or anecdotal results are at this point. Next slide. And if you're in California, this product just hit the market, and you'll see here that this is actually a 2-to-1 THC to THCV ratio. So definitely likely to be psychoactive, but it is coming from the chemovar. I think it's Pink Goddess is the chemovar out here in California. I haven't seen any of my patients try this one yet. I haven't had any need to try it, but this is another product that's out there. And I think, when the question always comes, when people are trying a new cannabinoid is, what can I expect? Am I going to feel, any sort of euphoric feeling from it, any kind of high? Well, of course, you can see there's 3 different products here. The first 2 have little to no THC in it. So I think it's unlikely that you'll feel any euphoria or that quote unquote high that comes with THC. With this particular product, I think it's quite likely that you'll have a euphoric effect. If you're going to be using it for weight loss, the questions of course become, do I need to change my diet? Should I increase my exercise? And I think, the truth is we don't know yet. That one study, that Nitro-V study, demonstrated that people did not need to change their diet or their exercise regimens, and still on average lost about 10 to 11 pounds in that 90 days. So we have very limited studies of dosing in humans. One study did use an oral 10 milligram THCV to assess its effects on food aversion and reward. It was a double-blind study of 20 volunteers, so small study. And it found that THCV increased neural responding to rewarding and averse stimuli and may possibly lower depression. So there's some promise there. Another study showed that 10 milligrams of THCV IV, likely an isolate, decreased the psychological impairing effects of THC when co-administered. So again, looking at maybe using it as an antidote, probably more effective than CBD to stop that THC impairment. And finally, a double-blind study with 62 participants assessed glycemic and lipid parameters in type 2 diabetics. And the dosage of THCV was either 5 milligrams in one group, or 100 milligrams of CBD. It was THCV 5 milligrams with 100 milligrams CBD. And then another group got 5 milligrams CBD and 5 milligrams THCV. And THCV was shown to reduce fasting plasma glucose and improved pancreatic B cell function, as well as plasma levels of HDL. They were unaffected, and CBD showed to decrease resistant and increased glucose-dependent insulinotropic peptide. So I think really the takeaway for me here, if I'm seeing these products on the market, is to really make sure that we're keeping good data on our patients in terms of what they're experiencing and monitoring them. Because even though I think, we've proven that plant-derived THCV is not an inverse agonist, right, Tim?
Right.
that we're not so concerned about THCV, plant-derived THCV possibly causing depression or suicidal ideation like we saw with the Ramonabant, but we certainly want to be monitoring our patients, because even in my experience, patients who use THC over time can start to experience some depression. So again, that constant follow up and follow through and monitoring to make sure that they're continuing to receive benefit from the product. And I know we're at the top of the hour, but we got quite a few questions in here. I'm happy to stay for a few minutes, Tim, if you can, to try to answer.
Yeah, definitely.
Some of them.
Let's see. So you want me to read them?
I see some here. Okay, looks like Gabby's asking, well, Maureen, is there you said good to see a CBD, very low THC product in the dispensary. Bell Eagle's carrying them in Denver. You must mean the Wanna Fit, I'm assuming. For someone that wants to use it for neuropathic pain, but does not want to lose weight, is this a good choice? That's a great question, Gabby. I don't know. The question is, will they lose weight? How much weight will they lose? Definitely want to monitor them. Like, let's say you had a cancer patient who had severe neuropathic pain, but was also struggling to keep on their weight. It may not be a good choice. But it may be worth exploring if other cannabinoids haven't worked. That's my approach at this point, is to try to go with the tried and true cannabinoids that have the most research and that I have the most experience with, and are probably the more cost-effective cannabinoids. And then if those cannabinoids are not effective, we can start exploring some of these other cannabinoids where maybe there's less research. Shannon has this product. So you've tried the Pink Boost. It does work well for appetite, for suppressing, and does improve focus. That's wonderful. I love that. With the diabetic study, when CBD was given with THCV, the glucose lowering benefit disappeared. 5 milligrams of THCV BID was most effective with type 2 diabetics. Yeah. Would we expect to see anything on a urine drug screen? Yeah, right. I think you would with 2 of these products, where you could, there's still enough THC and they're likely to accumulate if you were using it daily. And because we're seeing that right now in hemp-derived CBD products, right? Some people in a full spectrum product are testing positive, even though the THC level is pretty low. But, other than that, I think if there's no THC in it, I don't think you would test positive. I'd be curious with the rare cannabinoid product if anybody's tried it.
I think one important thing to note about cannabis drug tests is that at least the initial one that's given is not very specific. So it sort of sweeps in detection of a bunch of different cannabis metabolites. I mean, generally they're looking for the COOH, but they're not very specific. So if you have other cannabinoids that are producing other metabolites, you might pop on the initial one, and then maybe you don't. It doesn't. It's not positive on the follow-up one that they're required to give. But I think if you're using any cannabinoid, unless you're using an isolate, I think there's always risk.
Mm-hmm. Yeah, home drug testing can be a great way to test yourself at home. I mean, you become a study of one, right? You're an N of one, but it's worth doing, because you can get I hate to promote Amazon, but you can buy like a 10-pack of the urine drug screens for relatively cheap and do some of your own experimentation. Mo, you can get, right now that product is available through Sava, get Sava. And the dollar store, that's great. I didn't even think about the dollar store for urine drug screen testing. But Mo, Sava sells it, and I don't know if they come up to your area or not, but, and it's by, the company is Cosmic View that makes the product, and they're great. They're female-owned, doctor-formulated company. They make really great products. Any other final questions, or looking forward to hearing people's feedback if they do try that one.
Okay, looks like that's about it. Thanks for everyone for staying late. We appreciate your time, and thanks for joining us tonight. We don't have anything scheduled yet for December. Eloise and I will get together and see if that's a possibility. We'd like to do one of these every month, but it hasn't been happening. But if we do, we'll let you know. I also want to remind everyone that we are having a protocol guide coaching session tomorrow at the same time at 4 p.m. Pacific. I'll send out another reminder tonight with information about how to join that. And mostly Eloise is going to be talking about anxiety. So how to use the protocol guide and cannabis to help treat your patients who have anxiety. So come on and join us tomorrow at 4 p.m. If you have any questions, don't hesitate to reach out. Thank you all for attending, and
Thanks, everybody.
Be a month out. Maybe we'll see you next month.
If not, have a good holiday season.
Bye-bye.